Pulsatile tinnitus, put it simply, is hearing your heartbeat in your ear. It is a pulsatile sound that matches the heartbeat and is audible. I would say that if, at least I'll talk about my practice with, experience of many, many years. If I recommend a surgical treatment to alleviate pulsatile tinnitus, say the likelihood of achieving that is 99%. I mean, I can remember very well the 5-10 patients over years that I thought I was going to help and I was not able to help them.
Welcome to the Tinnitus Relief Podcast by Treble Health. I'm your host, Dr. Ben Thompson, and today we're privileged to have with us a leading expert in the treatment of pulsatile tinnitus, Dr. Athos Patsalides. Dr. Patsalides is an accomplished neurosurgeon specializing in neurovascular disorders, a condition that can be as perplexing as it is distressing for those who experience it. Dr. Patsalides currently leads the Pulsatile Tinnitus Center at Northwell Health in New York, where he employs his deep expertise to diagnose and treat complex cases of pulsatile tinnitus. In today's episode, we will explore the possible causes of pulsatile tinnitus, ranging from vascular to ENT-related and muscular factors as well. Dr. Patsalides will guide us through the best diagnostic approach, including the crucial role of audiology, ENT evaluations, and specialized imaging. We will also discuss the various treatment options available, from sound therapy and psychology to advanced surgical interventions. Whether you're a patient seeking answers or a medical professional looking to expand your knowledge, this conversation is packed with insights that are not to be missed. So with that, let's welcome Dr. Athos Patsalides to the podcast. And first off, I'd like to review the basics of pulsatile tinnitus. Dr. Patsalides, what is pulsatile tinnitus and what are some common symptoms associated with it?
First of all, thanks for inviting me again. Pulsatile tinnitus, put it simply, is hearing your heartbeat in your ear. It is a pulsatile sound that matches the heartbeat and is audible. It could be intermittent or continuously heard by the patient, but the hallmark is that it's a heartbeat sound audible in the ear, which makes it very different from what we call tinnitus, which is typically a ringing or constant sound in the ear. And the difference is very important because the underlying problems are very different and the management is different.
So what are those common sounds that patients describe to you? Is there anything else like whooshing or thumping or anything like that?
So the typical sound is medium to low pitch sound that is best described as whooshing. It's like if patients have ever had a sonogram and they heard the blood flow on a sonogram, this is very similar, like a whoosh, whoosh, whoosh type of sound. This is the typical classic sound correlating with pulsatile tinnitus. There could be other descriptions, like sometimes people feel like wind is flowing through their ear. Sometimes feel like more like a hissing sound that is rhythmic. But I would say the typical sound is the whooshing sound.
So let's zoom out for a moment, because the core factor here is that the patient hears a symptom that any logical person would say is related to the ear, but the true root cause of the sound is likely not in the ear. Is that correct? And am I correct that your role is to be the primary investigator of where is this sound coming from, and can we do anything, any sort of treatment to stop it at the root cause?
In most patients, there's nothing wrong with the ear or their hearing or, the temporal bone, etc. The ear is working just fine, or the hearing system is perfect. And what they hear is abnormal blood flow adjacent to the ear. And that can be very important, especially for the patients with potentially life-threatening problems, right? Because that could be the initial manifestation of a bad condition. Again, this is not the most common scenario, but it's a scenario that is common enough that we have to always think about. But yes, you're absolutely right. The hearing system is not the problem.
So I'd love to learn from your expertise here. What are the most common causes, or how do you think through the diagnostic approach of what is causing this symptom of whooshing?
So it's a very broad topic, and I'll try to structure the answer so that it is easy for the audience to follow. I would say the principles of evaluating a patient with pulsatile tinnitus, the first principle is to exclude conditions or diagnose conditions that can lead to stroke. Because some of the, let's say, potentially life-threatening problems related to vascular conditions in the brain and neck, they can first manifest with pulsatile tinnitus before they declare any other problem, before they declare stroke, hemorrhage, seizures, etc. So a patient who presents with pulsatile tinnitus deserves workup, at least to exclude these life-threatening conditions. The second objective then is to see if there is a condition that can be treated and provide relief from the pulsatile tinnitus for the patients who have debilitating pulsatile tinnitus that affects their quality of life. So this is kind of like the second principle. And third, I would say if somebody does not have debilitating pulsatile tinnitus and is not at risk for stroke or a life-threatening, does not have a life-threatening condition, these are the patients that can be monitored and managed with behavioral therapies, with masking therapies, things that we're going to talk about later.
And how many patients with a primary complaint of pulsatile tinnitus have you seen over the years, or your care team that you're managing seen over the years?
I would say we started very slow in 15 years ago, and it was really a new diagnosis and a new symptom in our clinic. At this point, I've seen thousands of patients with pulsatile tinnitus, and we learn from the patients, and there's still a lot of work to be done, but we came a long way from the last 15 years, no question.
So let's go through the possibility or the percentage of which patients have causes related to their veins, which patients, how many have causes related to their arteries, and are there other potential causes like actual ear problems or muscular conditions? Could you give us some sense of the breakdown of what are the causes?
Absolutely. I think this depends on the demographics of the patients also. We know that we published this work, young patients, especially young women, the vast majority, at least 80% of them who present with pulsatile tinnitus, this will be related to venous sinus stenosis. And this is a work that I've done more than 10 years ago now that showed the venous sinus stenosis as a cause of pulsatile tinnitus and showed how effective treatment can be with stenting to relieve the stenosis in this particular group of patients. That doesn't mean that every patient with pulsatile tinnitus needs surgery, and doesn't mean that every patient with venous sinus stenosis needs stenting. In older patients, I would say over 50, over 60 years old, there is no clear leading cause of pulsatile tinnitus. This could be, often they have arterial pathologies. Very often they start creeping into the territory of ENT problems like hearing nerve problems, temporal bone abnormalities, like semicircular canal dehiscence. There could be like problems related to sensitivity of the hearing nerve. So I think the older patients get, there is more consideration for ENT problems. And I think that's more or less what we can say in terms of what is the leading cause. It depends on the demographic. Thankfully, I would say, just for reassurance to the people who hear and they have pulsatile tinnitus, is that the life-threatening problems are the least common in a patient with pulsatile tinnitus. But it's important to exclude that. I think most patients, they have what we call benign problems. But again, they deserve the minimum workup, at least to exclude the conditions that can lead to stroke.
Understood. I think what we're discussing here is so crucial for someone with tinnitus or any health condition, is identifying the symptoms and then trying to target what is the most likely root cause, because when we treat the root cause, the symptom improves. And that's what we're really after. When I'm sitting here hearing you describe this, I imagine many patients who speak to you and are in your clinic, they say things like, wow, you understand this. No one else does. I've been to multiple doctors. I went to the ENT. I got the hearing test. I tried to do research online. But the depth of knowledge you have and specificity of the systems at play and the potential causes is really comprehensive. So I'm wondering if you could provide some advice to someone who wants to take a few steps towards a targeted diagnosis And maybe they've already been to multiple doctors and are still struggling with this.
I think you raise an important issue here that I think is universal, like the social aspect of this condition, because there's a very high chance that the patient with pulsatile tinnitus today will probably not be able to explain to his friends or family, and even worse, to his physicians, what is going on. Because there's a good chance people are going to say, oh, you hear something in your ear? Yes, I hear it too, or I have ringing in my ear also, or, our neighbor has the same problem and there's nothing to do and just accept it and live with it, or take Tylenol, it's going to go away, or something really makes no sense. And it's a lot of, this causes a lot of anxiety on the patients. Many times they feel like they have no support. And truthfully, many times they don't get the medical care they deserve. And yes, I hear it a lot that thank you for listening. Thank you for understanding what's going on. Nobody else knows. I think there is a lot more knowledge today compared to 5, 10, 15 years ago. And at the same time, I think the patients, they have to keep searching for answers. There's like support groups online, physicians like me are accessible. Your webinars, your work. I think there are resources today, and I think the patients, especially the younger patients and the that are more like into using the internet and social media, I think they do end up getting some answers, even if they have to travel across the country.
We've outlined a great case as to what are the potential problems here. Now let's talk about treatments, what doctors can do or what you listening might be able to find. Dr. Patsalides, what do you recommend in terms of treatments and therapeutic approaches here?
So the therapeutic approach is complex, because again, I mentioned this already. It has to take into consideration the risk of the underlying condition, which is very variable, the risk of treatment, and the impairment on quality of life from having pulsatile tinnitus. You see on this slide that I have up that the first question that needs to be answered is whether this underlying condition that is causing pulsatile tinnitus has an associated stroke risk. It's a life-threatening condition. In that scenario, we treat the condition to prevent stroke with secondary benefit, alleviating the pulsatile tinnitus. So this is very straightforward for a medical practitioner like me. Stroke risk, you undertake the treatment to prevent stroke, and secondary benefit is resolution of the pulsatile tinnitus. These conditions could be the AVM or the dural fistula that we mentioned, or it could be the carotid dissection. It depends on the underlying condition, whether this is a medical treatment, let's say with aspirin or blood thinners, or is a more complex treatment called embolization that is, needs to be discussed, and it can be more or less complex and more or less risky depending on the specifics of each patient. Then the second group of patients that we need to consider is the patients with venous sinus stenosis. The first treatment objective for these patients is to understand if they have IIH, intracranial hypertension, or not. If they have intracranial hypertension, then we can try medical management for the intracranial hypertension. And if that does not work, then we consider stenting, venous sinus stenting, as a treatment option. For the patients who have venous stenosis but do not have IIH, they have isolated pulsatile tinnitus, then very rarely we see effect of medical management. I wouldn't say it's not impossible, but it's almost impossible. So these patients can be considered for venous sinus stenting if the pulsatile tinnitus is debilitating. Because if the pulsatile tinnitus is not debilitating, then we can monitor them and observe them. And that's kind of like the way to approach the benign conditions that can cause pulsatile tinnitus. We can always do more surgeries and more procedures. The question is it necessary for this patient? And for a low risk or a minimal risk condition, we should offer a low risk treatment if it's going to improve the quality of life. But if the quality of life is not impaired, then we can monitor these patients, and then we have the options of behavioral management, masking therapies, etc. But I would say in terms of across the board, the majority of treatments for pulsatile tinnitus are either for dural arteriovenous fistulas or for venous sinus stenosis. This is kind of like the most common treatments the most common surgical treatments, and you have to factor in everything we discussed.
Understood. And when do you collaborate with your ENT colleagues, physicians who specialize in the ear and medical diagnosis and treatment surgeries of the ear? How common is that?
First of all, this has to be a multidisciplinary approach. This cannot be, I cannot evaluate everything. I cannot do the ENT work, and the ENT work in the ENT physician cannot do the work that I do. So we have to have a team approach. And I honestly ask every patient to be seen by ENT because there could be ENT conditions that cause pulsatile tinnitus. This could be problems of bone, like what is called dehiscence of the temporal bone or dehiscence of the semicircular canal. It could be a tumor in the hearing system, in the nerve, or in the temporal bone that is what they call a hypervascular tumor that can lead to increased blood flow close to the hearing system. And it's not a vascular condition, but it's a tumor with high blood flow. So the patients need to be seen by ENT, period. I also send every patient to be seen by an audiologist. They need to have a hearing test, and that becomes even more important in, I would say, the older group of patients, because that can also lead us towards hearing nerve problems, potential benefit of hearing aids, etc. And then the last discipline that we need is also the ophthalmologist for patients with venous stenosis that may have IIH, which may present with vision problems. The ophthalmologist is also important. So we need a lot of people assessing these patients as a group.
We have a team of audiologists at Treble Health in our telehealth practice, specializing in tinnitus. Pulsatile tinnitus makes up about 5 to 10% of the patients that we see. So I want to pass it back to you here. Once you've done the treatment considerations and you've pursued treatments with some of your cases, what is the common next step? Does the treatment, remove the pulsatile tinnitus, the whooshing, most of the time, some of the time? What about for that section of patients that you collectively decide a surgery isn't the right thing for you at this time? What do they do next? Because often that's where an audiologist like myself would come in and say, hey, there's help that can be done despite us not getting to the root cause as much as we'd like to. So I'd be really curious about your thoughts there, because it's quite important.
That's a great question. I would say that if, at least I'll talk about my practice with, experience of many, many years. If I recommend a surgical treatment to alleviate pulsatile tinnitus, say the likelihood of achieving that is 99%. I can remember very well the 5-10 patients over years that I thought I was going to help and I was not able to help them. And that has to do with, treating patients early on and not having the knowledge that we gained over years. But I would say 99% resolution or near resolution of the pulsatile tinnitus if I recommend a surgical treatment for that purpose. Then there's patients who have pulsatile tinnitus, but it's not debilitating. They will benefit from a surgical treatment, but since it's not debilitating and they are not at risk for any catastrophic event, these patients we don't treat. We know what's the cause. If they come back a year, 5 years later, and they say now it's much worse, the pulsatile tinnitus gets louder, is constant, then we can treat them then. And then unfortunately I would probably say there's like a 20-30% of patients that despite all this workup and despite all the fancy imaging and seeing all the experts, we don't really understand what's going on. We can exclude a lot of conditions, essentially every condition I mentioned in the slides, but we don't have a diagnosis. And the ENT excludes all the ENT conditions, and I still no diagnosis. And that can be devastating for the patient, because if they have debilitating pulsatile tinnitus, yes, they are reassured that they don't have a catastrophic condition, but they're still live a very difficult daily life because of the impairment from the pulsatile tinnitus. And for these patients, I think what we can offer is, in the appropriate patient, like the behavioral management, and then is the masking therapies. And I think you should talk a little more about that because you are the expert and not me.
If you have pulsatile tinnitus and are looking for help from an audiologist, consider working with Treble Health. I'll include a link right here on the screen where you can schedule a free consultation. That's over Zoom with one of our doctors of audiology who specialize in tinnitus, including pulsatile tinnitus. Right there, you can book the free consultation on the screen. Let me talk more about the sound therapy treatments. When professionals describe masking, what we generally mean is the sound of the whooshing or the sound of pulsatile tinnitus in this case. Let's say it's at a 5 out of 10 of volume. So in most quiet places like reading a book, falling asleep at night, trying to work and focus during the daytime, indoors, it's very quiet, and that 5 out of 10 sounds very loud. It's very intrusive. But if I'm at a restaurant, if I'm around people talking, if I'm playing music, the 5 out of 10 whooshing isn't that bothersome. It's more manageable. So essentially, what an audiology treatment for pulsatile tinnitus would look like is it's bringing in sound to mix in close to that 5 out of 10 level of whooshing, and it provides the benefits of being able to concentrate and focus and relax in quiet environments. And it takes that whooshing or the pulsatile sound and it pushes it more into the background, less into the foreground. There are some immediate effects through devices like sound therapy devices that go up and behind the ears with a little speaker inside of the ear canal. Those can also be called maskers. Those can also be referred to as hearing aids programmed for tinnitus, or in this case, pulsatile tinnitus. The general theory or model to follow here is called tinnitus retraining therapy. And I studied with the founder, Dr. Jastroboff. I specifically asked him, and I've used this in my practice, what about pulsatile tinnitus? Because what this model does is it recognizes that certain physiological sounds in our body, the brain has learned to reduce our perception and awareness over time, right? So think about the sound of our breathing in and out. If I really focus to it, I can often hear it, but I'm never thinking about my breathing despite the physiological sound nearly always being there. And I'll go one step further. This is very relevant. The sound or the vibrations of our heartbeat since we were born, we've never really thought about it. It's just been a constant sound that our brain learns to habituate or reduce the awareness and perception of. So I asked Dr. Jastroboff, my mentor, I said, what about the pulsatile tinnitus where there's fluctuating sound? And he said, well, habituation and that model, it also works for fluctuating sounds. And I think we can all relate and understand why when we think about our own heartbeat. So all this to say, one is not stuck with the difficulty or the 5 out of 10 level intensity they have, that in many cases, the pulsatile nature, how much it affects us, how much we're aware of it, it can improve and get better over time, often through sound therapy treatment, through tinnitus retraining therapy with an audiologist. So what do you see as the most common causes? And perhaps you could address how someone with the symptoms should go about thinking of the various causes and subtypes and what they should do about it, really.
I would say that to understand or to categorize the conditions of pulsatile tinnitus related to vascular problems, the first step is to understand that there could be 3 types of categories. I have a slide shown on the screen that shows that the vascular causes of pulsatile tinnitus can be categorized in arterial causes, in venous causes, and arterial and venous causes. I assume most of the audience know that there's 2 types of blood vessels, the arteries and veins. They have different purposes and often different diseases related to them. That's why it's important to categorize them in that fashion. I will start by discussing the arterial causes and then the venous and then the arteriovenous causes. On this slide, you can see the arterial causes of pulsatile tinnitus. The most common one is a condition called arterial dissection. Think of this as of a trauma into the wall of the blood vessel, like the carotid artery or the vertebral artery. These are blood vessels in the neck that travel through the neck into the skull base and into the brain. And when they patient suffers from dissection, there is significant stenosis of this blood vessel as related to this event, which can cause turbulent blood flow and cause pulsatile tinnitus. Patients with connective tissue disorders and fibromuscular dysplasia are prone to this condition, so we have to take this into consideration from the patient's history. Another relatively common condition, which rarely presents with pulsatile tinnitus, though, is carotid artery stenosis. Probably most families in the United States or internationally, they have somebody or they know somebody who had stenosis of the carotid artery related to high blood pressure, diabetes, smoking history, obesity, etc., who needed surgery or stenting for that. So patients with carotid artery stenosis, for the same reason, changes of blood flow related to the stenosis may also present with pulsatile tinnitus. And the last of the arterial causes I want to mention is something called aberrant carotid artery. This is an anatomic variation that the development of the carotid artery in the scalp base next to the ear is different than most of us. It's not a true disease, but it's aberrant anatomy. And that over time can develop into abnormal blood flow in the area of the ear that can cause pulsatile tinnitus. But from these three causes, the dissection is the most common one. The next category, and this is what we see on our slide now, is the venous causes of pulsatile tinnitus. The most common of the venous causes of pulsatile tinnitus is the venous sinus stenosis. This is stenosis of the large veins of the brain, specifically what is called the transverse and sigmoid sinus. These are large veins within the skull, adjacent to the hearing system, adjacent to the temporal bone. This is by far the most common cause of pulsatile tinnitus in young patients, especially women. And young can be a relative term, but I would say in the ages of 20s and 30s, probably 80% of patients with pulsatile tinnitus do have venous sinus stenosis. This condition itself can manifest with isolated pulsatile tinnitus, meaning no other symptoms, or can lead to a condition called intracranial hypertension or idiopathic intracranial hypertension, IIH, which is also, you can see that on the slide. So these patients need to be worked to understand whether there is isolated pulsatile tinnitus or the syndrome of IIH, the syndrome of high pressure in the head. The second most common cause of venous disease that can cause pulsatile tinnitus is something called venous sinus aneurysm or venous sinus diverticulum. Think of this as an outpouching of the vein adjacent to the temporal bone, adjacent to the hearing system. And that over time can lead to increased transmission of sound from the vein to the hearing system. This is not a dangerous problem by itself. It's not the type of aneurysm that people will have a hemorrhage and die from. So it's a benign condition, but it can lead to debilitating pulsatile tinnitus. Other conditions are the prominent mastoid emissary veins. These are large veins in the temporal bone behind, in the area of the ear that can lead over time to increased flow, and the ear will pick up that flow. Then there is a condition called jugular vein aneurysm or jugular vein diverticulum. The jugular vein originates from the scalp base right underneath the temporal bone and goes down into the neck and into the chest. And at the upper part of the jugular vein, we can have this outpouching, this aneurysm that can also lead to increased transmission of blood flow into the hearing system. And last, the jugular vein stenosis is a condition typically in the upper cervical spine, that leads to change of blood flow. Instead of going downwards into the chest, because of the stenosis, the blood will go backwards towards the hearing system, towards the ear, and the hearing system will pick it up. All these venous causes really are benign problems. So these are not conditions that can lead to stroke or hemorrhage or seizures or death. Patients with IIH are at risk for vision loss in extreme conditions, so there is some consideration there. But overall, the venous causes are conditions that are benign and should be treated if the pulsatile tinnitus is debilitating. And the last category, and I know this is long and you can see on the slide here, is the arteriovenous causes of pulsatile tinnitus, meaning the disease involves both arteries and veins. And these conditions are potentially life-threatening and dangerous and need careful consideration by an experienced provider. This is the arteriovenous malformation, goes by AVM, the dural arteriovenous fistula, which goes by DAVF, and the PL arteriovenous fistula. These are, think of this generally as abnormal connections between arteries and veins. They occur in the brain or the surface of the brain and can manifest with pulsatile tinnitus as a presenting symptom, but can lead to catastrophic events if this is not diagnosed and, when appropriate, treated. I think this is like a good review of the vascular causes of pulsatile tinnitus. If we want to talk about the workup actually, once patients get to a knowledgeable provider, the workup is, I would say, straightforward. We have, a lot of experience at this point on how to evaluate these patients, and the experience and the evaluation involves, first of all, good clinical exam, including a good history from the patient. Need to understand the pitch of the pulsatile tinnitus. Some patients, they have apps on their phones and they try to match the sound that they hear with a sound of certain frequency. Sometimes you can palpate an abnormal blood vessel that indicates the possibility of a dural arteriovenous fistula. This would be like in the mastoid bone behind the ear, like against the bone. Other important things is to ask the patient if the sound improves or resolves by compression in the neck under the jawbone. This is compression of the jugular vein that may lead to resolution of the pulsatile tinnitus. This is an important finding of the physical exam. And the last is whether the sound changes with neck movements or jaw movements, because these also can indicate certain pathologies. The ophthalmological exam is important to assess for vision problems in patients there is a concern for IIH. Patients with venous stenosis, for example, there should be a concern for IIH, and ophthalmological exam is important. ENT exam, audiological exam, and lastly, imaging. Imaging is important. Every patient with pulsatile tinnitus should have at least basic imaging to exclude the life-threatening problems that I mentioned. My practice, and again with experience of over many years, I recommend MR-based scans, MRI scans of the brain, MRA scan. MRA is for the arteries, and MRV scans for the veins. And this is what you can see on the slide that I have up. If MRI is not possible for either medical reasons or presence of a pacemaker, etc., we can get a CAT scan instead. We get a CT of the head, CT angiogram of the head, and a CT venogram of the head. And in selected patients, we also get CT of the temporal bone or evaluation of the blood vessels in the neck. That depends on the exam, findings of the initial workup, etc. But at this point, the workup of pulsatile tinnitus is pretty much straightforward, and every patient should at least have the basic evaluation.
And yeah, I love the collaboration here between your work, Dr. Patsalides, audiologists, ENT physicians, and other professionals. How can someone follow your research or the work that you and your group are doing?
I think I have a website that is meant for education of patients. I'm accessible. I have an email that patients can email me, and it takes me a few days to respond, but I respond. And I'm obviously available to see any patient, in telehealth or in person. I'm blessed with a great team and great colleagues, and we have a very big practice for pulsatile tinnitus patients, from all over the country and international. So we'll try to do the best we can and keep advancing the field.
Thank you so much, guys. If you're interested, you can check out the Pulsatile Tinnitus Center at Northwell Health in New York. Dr. Patsalides, thank you so much. This is going to help thousands of people, and it means a lot to me that you're here.
The pleasure is all mine. Thank you for inviting me. Thank you for the work you do. And I think every discussion adds a little bit to the knowledge that we have. And I learned from you today too. So
perfect. Thank you so much. I'll see you soon.
Be well. Take care.